Well, good morning, everybody. Welcome to today's Medical Grand Rounds. A couple of quick announcements first. For those of you who either were here last week, or perhaps even more if you couldn't make it, we have a few printed handouts from last week's talk from Dr. Michael McDermott on hypercalcemia. Ruth Parker can also make those available electronically for last week's talk or nearly all of our talks, so please reach out if you're interested in slides in general. A reminder for next week, do please come join us for one of our talks in our High Value Care series. We'll be hosting Dr. Otis Browley, who's the Chief Medical Officer for the American Cancer Society. Today, I am really delighted to introduce our speaker, Jen Kakal. She has been specializing in pelvic floor physical therapy for more than 10 years. She works with men and women of all ages and a variety of needs, but does have a particular passion for helping women with sexual dysfunction. Jen is a manager liaison for the pelvic health team in the Oregon region, along with clinician MJ Strawhall, a widely known expert in this area. Through this manager role, she's really working to grow and support this common and important need. We're so grateful for her wonderful care. Also, she's become an increasingly passionate teacher in this area, joining us here for Medical Grand Rounds and other invited talks, and has graciously agreed also to begin hosting our internal medicine residents so that they can learn some of this skill set, really who to refer and how to best manage our patients. So thanks, Jen.
Yeah, thank you. And thank you very much for having me here today. I know that these talks are valuable, and I hope that you leave today with some great information. I think a lot of you are probably pretty familiar with what physical therapy is and kind of the services that we provide. But I think one of the things that people probably are not as aware of are issues that we deal with being able to pee, poop, and have sex. And it's really a huge quality of life measure for our patients and a lot of people that come into the clinic. And we have a specialized team of women that deal with these issues for both children, women, and men. So just a few kind of objectives of what my goal, is for today's talk. Understand and review kind of the literature that's there. There's not a ton of literature, regarding physical therapy approaches. I think that's something that us as a field needs to be better about, is publishing our research. But I do want to highlight a few things that are there. One, it may be appropriate to refer to physical therapy, some common diagnoses that we see that you may also be seeing in clinic. Understand the difference between a pelvic floor physical therapist versus just an orthopedic or a regular physical therapist that you may refer for balance, gait, other pain disorders that an individual might have. And then the treatments and interventions that we have that are different than what you might be used to. And I did bring kind of a show and tell, I guess, if you will, that I'll hold up some of the devices that we use and have a couple slides of some of the unique modalities that we have to help support these people along this path. So there's a huge umbrella of what pelvic floor disorders are. I've kind of tried to break it up as simplistically as I could, but over the bladder overhead, the diagnoses that we see are urinary incontinence, which can be urge, stress, or mixed, combination of the both. Dysfunctional voiding, inability to urinate, and overactive bladder, so urgency and frequency symptoms outside of any incontinence that the individual might have. And a lot of the research that is available is geared towards women rather than men. It's a sensitive topic for any of us, I think, to talk about, but I think even more difficult for some of our male patients to disclose some of these problems. Next is kind of a more pelvic pain, bowel disorders. So we do see a huge number of women with pregnancy and back pain that then can kind of lead to a pelvic organ prolapse. We also see this outside of women that have children. Those individuals that have a hard time defecating or voiding, the more pressure that they create in their abdomen, the more likely they are to stress those ligaments that support the bladder that then create some long-term issues. So even catching our pediatric kiddos that may have some constipation issues and teaching them the correct way to void can be really successful in allowing them to not have problems later in life. Pain disorders, interstitial cystitis, coccydynia, pelvic floor muscle overactivity or hypertonicity. That's probably where the majority of my caseload lies, is that increased tone of the pelvic floor that creates a lot of pain in these women as it grabs kind of the nerves throughout the pelvis, and can create some really odd pain presentations. Bowel disorders, fecal incontinence, dysfunctional voiding, and constipation. Some of you may be aware of what is actually pictured here, but it's called the squatty potty. It is becoming more widely known as a way to allow you to evacuate your bowels a lot easier, and it is awesome, actually. I think if anybody's having some issues with constipation or having a difficult time voiding or defecating, it just allows your pelvis to align in a little better position. I think there's been a lot of research to show people that actually squat down to the ground to be able to evacuate has been a much easier process, and this is kind of where this manufacturer created this. So you can get it. I saw it at Costco this weekend. Didn't know Costco had it, but that's pretty awesome. And it's at a lot of other retail stores, but it is something for those people that have some constipation issues that we do recommend that they try this, or even having a step stool just to try, and then maybe going this route. But we've been recommending that for years, and I think all of us as physical therapist reps that we didn't think about marketing it and making some money off of it. Sexual dysfunction disorders. So again, this is kind of where, we see some men come into our clinic for chronic pelvic pain, prostatitis, post-erectional pain. Our women we see for dyspareunia or vulvodynia, so really pain kind of around that vaginal opening. Most of the time we're seeing those sexual pain disorders in women that are post-cancer treatments or post-menopausal, where there's been a pretty significant loss of estrogen and change in the tissue, that the tissue doesn't become as, kind of loses a lot of the elasticity that is there, and then the ability to have sex becomes quite uncomfortable as they don't have that same lubrication they once had before. So diving into some of the statistics, most of the research again, is geared towards women rather than men. We tend to seek out more services when we have problems, and so there is more information for us. The greater number of children that someone has can definitely put them at higher risk for pelvic floor disorders or urinary incontinence. I can recall a conversation with my mom years ago about, you laugh at something and she had this look that was like, oh God, that wasn't supposed to happen. And I, was like, are you okay? And she's like, honey, that's just what happens when you have babies. You'll understand one day. And if she was still alive today, I'd be like, no, that's not okay. It's not normal. You don't have to kind of live that way. There's actually a lot that we can do to the muscle structure itself to support the pelvis and prevent that from happening. So, getting connected with you guys, I think, is huge to allow for an outlet for some of these individuals that may be affected by these disorders. Need for multidisciplinary approach. It was noted 116% increase from 2000 to 2010 in females with pelvic floor dysfunction. And the statistics were taken from a group of women that were 30 to 89 years old. It's a wide range, but that's really who's affected by this. Everybody, at some point is affected by this disorder, or can be affected by this disorder. So with the increasing age population, we really kind of feel that this is only going to increase and create more of a burden on you guys as providers to kind of figure out how to navigate this. And I think the fun part for us is to actually provide some success for these individuals. Oh, this slide is always a big tongue twister for me. Female vulvovaginal changes or genitourinary syndrome of menopause is underreported, underrecognized, and undertreated according to NAPI. Over 50% of postmenopausal women reported genitourinary menopause syndrome signs and symptoms, which can be that kind of vaginal dryness that I talked about, that change in estrogen that really pulls that out of the pelvic floor tissues specifically. Vulvovaginal atrophy syndrome symptoms associated with the decreased estrogen of the vaginal tissue is a major contributor to that pelvic floor pain. There have been, and I don't have it for you, updated guidelines on using actually vaginal estrogen for these women. That's definitely a conversation we gear towards you guys than us having any of those medication pieces. But there has been more research showing that even women that I think have had breast cancer and have had estrogen positive things, that they can actually use some of that local estrogen. So know that that may be something that you may investigate more. So here's my one key slide on men. We do see some men with post-erectional dysfunction, but 30 million men are affected by this and 6 million seek treatment. So really what I wanted to highlight was just the fact that there's so many that are affected by it but are maybe not comfortable with having that conversation with their physician about it. There are a few studies that actually showed improvement in these men with physical therapy. As we engage the pelvic floor, we increase the blood flow to the area, we're stimulating the other tissue that's around there, both through the abdomen, the glutes, and the pelvis. And so some of that even allows for just some tissue recovery and some tissue healing. So improvement to normal, this group of men that they surveyed, 40%, so they got back to their normal. 35 to 45% said there was, some improvement. They felt like it was a benefit to have gone. But there was, the one thing I found interesting was greater improvement with pelvic floor muscle control than with medication. MJ Strawhall and Judy Marvin, I think a couple years ago, had done a presentation at Ground Rounds. And this slide really kind of spoke to me from their presentation. And the statistics really kind of hold true till now. 52% of Medicare respondents reported accidental urinary leakage. Of those with leakage, 13.2 reported it was a big problem. 47.3 reported it was a small problem, but 44.2% reported that they had spoken to their provider about this issue. Have you in your practice had patients come through and disclose that they have, pelvic floor problems, whether it be fecal incontinence, pelvic pain, or urinary incontinence? I see some hands, or I see some nods. Good. Did you know that physical therapy was possibly an option for these individuals? Yeah, okay, good. So barriers to care, I think, is, don't ask, don't tell, being comfortable about having the conversation. I think also not understanding or lack of knowledge about what services may be available for patients. And definitely physical therapy is an option. Medication can be an option. Surgery can be an option. We're not the only service that is there, but we're definitely one of those conservative options that, can provide some success for these people. And even embarrassment about talking about what is happening in their body. I think the most embarrassment, and even with our patients, comes from those that are affected by fecal incontinence. A lot of them don't want to leave their home because it's embarrassing. They feel like they smell all the time. They have to be careful about what they wear, what they do, how they rise out of a chair because things might accidentally escape out. And so really kind of giving these people a quality of life back, I think, is important. So getting comfortable with the language. It's okay to say vagina and penis and sex and, all those things. I think we sometimes tiptoe around the issue, and even those younger clinicians that I mentor into this, they, gosh, I turn all shades of red when I have these conversations. I'm like, yeah, that's normal. Pretty soon it won't happen. But if you don't ask, you're missing part of the picture of what may be troubling your patient or what really may be affecting them at home. So just getting comfortable with that, asking questions. I'm gearing all my orthopedic clinicians that I have to just ask questions, especially even our athletic population, our younger athletic population, is, do you leak? Those that do a lot of jumping, running activities are more likely to have that leakage later because of the stress that it causes to their pelvic floor at that moment. So providing some stability then, again, can help long term. And being direct. And one of my patients said she had a really good conversation with her physician, and she got connected with me after having that conversation. But she said he kept asking about how things were down there, and she wasn't quite sure what he meant by down there, because she's like, oh, I've got, back problems, and I've got some hip problems, and she goes, he kept saying down there, and she goes, well, I still leak, right? And he goes, oh, okay, well, then we need to get you, connected with a physical therapist, and he, made the referral. But I think actually having that comfort of, saying, hey, do you Do you leak when you cough? Do you leak when you pick up your child? Do you leak when you rise out of a chair? Does gas escape when you don't want it to? That's also kind of a trigger of understanding that pelvic floor may not be functioning quite the way that it should. So physical therapists. Every physical therapist comes out of school. We do our 3-year or 4-year undergraduate degree, and then you have your 3-year graduate degree with clinical rotations kind of spaced, through those 3 years. All of us come out as generalists. There's very few that come out as more specialists or have an interest in a specific specialty area. But really that does not happen until you graduate from school. You do postgraduate work, CMEs, residencies, and fellowships. We have those all available as physical therapists. What I think the biggest piece of the pelvic floor work is we do take at least 3 courses. So the APTA, I think my next slide talks about it, offers 3 courses to kind of be a pelvic floor specialist. It goes through all levels of pelvic floor dysfunction, from children to geriatrics. It's a 3-day, like 7 in the morning until 7 at night classes. A huge lab portion of these classes where anything that we're gonna do to that patient, we have had to have done to ourselves. So those classes are, I would say, fun in the fact that you have like 30 other pelvises to investigate while you're there to know what scar tissue feels like and what things look like. And I've had so many children take a look at my pelvis. It's a weird show and tell type of class. But we spend a lot of time diving into our tissue. If we don't know what it feels like, how can we then have that conversation with our patient about what they may be experiencing and where we're really placing our hands. So I want to say the last course I took, audited a class a couple years ago, they put us in a beautiful room. It had enough space for us to use, to be patient and to be clinician, but the whole back part of the auditorium was windows. So we spent probably the first 30 minutes of our class that day actually taping up sheets along all of the windows because we're half naked through basically the entire class. The catering service, we had to put a huge sign and makeshift curtains up at the door to say, leave all food at the door, do not enter. We all kind of laughed about it, and the next time we went to that same hospital, we requested not to be placed in that room. We're okay with the room with no windows for these classes. But the exams that we do to each other are vaginal exams and are rectal exams. And when you take your test, you are tested by the instructor who knows whether you're on the right structure or not. When she says, identify this structure for me, you better know where it is. So all of our physical therapists, at least for Providence, there's a lot of pelvic health clinicians in the area. There's great private practice clinics that we share patients with and have communication with those clinicians. But those of us that practice in Providence, we have decided to adapt and adopt the APTA courses that they have. We like those courses because they're the most evidence-based. They have the greatest amount of lab. And we wanted to try and not standardize our product of care, but allow you guys to understand what your patients are getting when they're being sent to us versus maybe being sent somewhere else. So all of our clinicians have the same training. If they've come into our health system and have other trainings, we ask them to go ahead and take these APTA courses. And that way we're all speaking the same language. So 24% of participants noted a decrease after urinary incontinence after education completing a bladder diary alone. So a lot of our treatment techniques, at least in the first visit, are education-based. Most people don't know they're gonna have a pelvic floor exam or a rectal exam. I think my male patients are more caught off guard by that than my female patients. Not that we're more accustomed to it or used to it, but I think we just kind of expect that may be part of the process. So that first visit that I have with people, a lot is really understanding their story, figuring out what their patterns are, giving them actually a bladder diary to fill out and a food and fluid diary, so I really understand what they're putting into their body and really what's coming back out of it and what that pattern might be, because we can make some pretty easy adjustments just based on that information. I did give you, or I had some handouts, and if you guys didn't get one, I can try and get some more. But this was kind of created as just a quick reference on a pathway to treat. So the first, section of questions is really one of our outcome measures called the ICIQ. It just helps us kind of decide at that point of entry where they fall along the dysfunction. How much dysfunction do they have? How impaired are they? And then retaking those measures throughout our series of care to know, okay, one, we're seeing changes, but really is the patient seeing changes? So it is kind of a subjective measure on what they're feeling, but I think that's important for them to feel success and to feel that they're involved in the care. It identifies through kind of what the types of urinary incontinence are, how to classify those, what diagnoses you might use, and then what the treatment options are. So, physical therapy, behavioral options, which we do also, kind of educating on the bladder diary, taking a look at their food and fluid intake. The second sheet of the handout goes through medications that may be an option for individuals. Again, it's something that we relied on our pharmacy partners for, since it's not something that we dip our hands in at all. It's not something I'm glad that I don't have to deal with medications. That's the nice thing about my role as a clinician. I rely on you for that. But these are some of the medications that are available. So physical therapy, we definitely, as I mentioned, look at the behavioral modifications, understanding their bowel and bladder issues, program, training. We look at posture and body mechanics, their use of breathing. So pelvic floor muscle training will be something that we absolutely look at. Reducing Valsalva for pelvic organ prolapse or stress urinary incontinence. So again, those people that may have constipation disorders, the more that they're creating that Valsalva, the more that they're actually stressing the ligaments of the organs inside their pelvis that then can fall out. And it is a very not normal thing to see coming out of somebody's body, and then we get them connected with other services at that point. Core strength, I'll dive into that a little bit more. And then our vaginal rectal examination and restoring the normal alignment. I would say the biggest piece about restoring kind of the normal alignment, I had a runner that came into the clinic and had a plantar fasciitis diagnosis and also had pelvic floor leakage. I had started seeing her for the urinary incontinence first, and she had disclosed, she's like, gosh, I have this, plantar fasciitis. I've been kind of waiting to deal with it because I wanted to deal with this first. And I kind of paused our session. I said, you know what, I kind of want to look at your feet first, because if your running's completely off, your pelvis is completely off, I said we might actually want to address a little bit of the mechanics of what's happening there and then kind of address what's happening in the pelvic floor. Spent a few treatments on her feet, got her in the right shoes, did a running analysis with her, got her on a different strengthening program, and then her incontinence actually got a little bit better because she had this just weird pattern of running because of the pain in her feet. As we got that a little more normal, pelvis got a little bit better, then I dove back into the pelvis, and we had much more success than we did when we were just looking at the pelvis. So we still want our clinicians to be looking orthopedically at these patients because, again, we don't want to miss anything that might be there that can be contributing to how the pelvis moves and engages those muscles around it. So this is a little bit of my show and tell. I'll grab a couple pieces of equipment that I brought with me today. Biofeedback, I'll have a couple different slides for you coming up. But vaginal weights, I use kind of with that runner that I had. So people that have a little bit better pelvic floor control and are leaking with a higher level of exercise. So her goal was to not just be completely wet by the time her marathon was done. She said, I'm soaked. She goes, luckily people think it's probably sweat than urine. She goes, but this is not okay with me. So I actually had her train with vaginal weights. And I encourage you to come up afterwards and even kind of hold them. They're actually pretty heavy. There's two different types. There's a new type we have. These ones are definitely more comfortable than kind of this plastic one, but you insert it vaginally and you have to keep it from falling out. So it can be a little bit of a game, or it can be a little bit frustrating for those individuals that don't have really great control, but they come in different weights. But they allow us to kind of get resistance training. It's very hard to get resistance training through the pelvic floor. You can do a little bit of it with using gravity to help, being in different positions, but for more of my athletic population, younger population, these can be really great to use.
Is that something they purchase and take home, or they just use them when they're with you?
They will purchase them, yeah. So it's not something I'll recommend with everybody that I see. But it is definitely an option for those people. And I mean, Amazon carries just about everything now, which I think allows people to not be as embarrassed when things come to the door that have, kind of weird labeling. These pink ones, pink and white, depending kind of what their resistance is, come in the most beautiful box you've ever seen with tissue paper everywhere. So, I mean, it looks like you're getting this really great present and you've got these inside. So they're getting kind of creative even on their packaging. The majority of my caseload, as I kind of mentioned, is those patients with sexual dysfunction. So those patients that have either hypertonicity of the pelvic floor or have kind of lost a lot of the estrogen that's there from cancer, whether it be breast cancer or even uterine pelvic cancers. And that tissue really kind of shuts down and locks down. So I do a lot of internal stretching with those individuals, but then we also have what are called vaginal dilators. These come in all sorts and sizes. So this is a smaller size. They start as small as this, which amazingly some women have to start with a size that is this small because it is just, whether it's the scar tissue that has kind of closed down around it, but this is all they can tolerate. I had a really cute couple come in. Husband would come in with her, and we talked about the dilators and what we were going to be doing with them and how they work. And, she kind of laughed when she saw them. And I said, they come in different sizes. And he's like, I want to see the large size. Which is the large size? Because that's the one we need to use. And was kind of trying to lighten the mood with his wife. But the large size is pretty big. So, this, I rarely kind of have people use a size that is that big. Most of the time they can get away with doing kind of small to medium and have the success that they need to have. Pessaries are an option for those individuals that have pelvic organ prolapse that is pretty significant. If it's mild and even sometimes moderate, we can do some different training with people to kind of help reduce what that prolapse is. However, I've had a few patients where the majority of their bladder was outside of their body, and we would literally tuck it back in before we could do our therapy sessions. Those are going to be more of a surgical route, or even a pessary, where it just kind of supports the bladder in there. One of the clinicians that fits my patient, she goes, I kind of think of it as a pop-up tent. You put it in there and it pops open and it kind of lifts everything off of the pelvic floor tissue. So one, I can get the muscle to do what I need to do, but then the patient is not experiencing this really heavy kind of pressure through their pelvis. Again, as we kind of talked about, muscle energy techniques kind of fall under that myofascial release, trigger point release, scar tissue mobilization, all things that we do as physical therapists, but that we may also need to do to the pelvis or internally, depending on what scarring might be there. And this is probably something I do more with my new moms after they've had a baby and they've had some tearing with a vaginal birth. That tissue is really traumatized, and it can be kind of that hypersensitive and kind of hypertonicity where it'll start to lift and affect their ability to have sex later, but also, they have a hard time voiding and defecating after these things. So really kind of calming down the tissue, doing some scar tissue mobilization internally can help reduce some of those nervous system reactions. And then internal and external techniques that we do. One of the things that is an option, and one of the things that I do call you guys and recommend for some patients is topical lidocaine. So a lot of times in clinic, when I'm looking at a woman's vaginal tissue, it can be incredibly red and just irritated. One, it's not getting good blood flow. The nerves are very irritated. It's super painful for the woman to have anything touch that tissue. Topical lidocaine actually, it kind of numbs the area, but just numbs locally. And so if they're wanting to go back to being sexually active with their partner and this tissue is a barrier, that can be a really great avenue for them. Obviously, we're still doing things in clinic. We're using the vaginal dilators to help stretch, but I have patients use that before they use their dilators at home and before they have sex. It comes in two forms. It's a liquid form, 4% solution, and it comes in a gel form also. One of my providers was always recommending the gel form, and I had a conversation with her as her patient came into the clinic. Her husband was really freaked out and scared because his penis went numb. So if the gel is not absorbed by the woman, it will be absorbed by him. You have to leave it on long enough and it has to have good contact. So I got to call her and have that conversation, and she was so upset. So she was never recommending the gel again. And the gel can be very useful. If they're using dilators, it can be great. But if they're using it as a lubrication for sexual activity, I kind of give the disclaimer that don't put a ton of it on there. The liquid might be a little bit better because you can put it on kind of a cotton swab, tuck it into the vaginal opening, let it numb the area, take it back out. You're more numb. It still doesn't take away all of the sensation. They still feel what's happening. It just kind of turns the volume down. But then husband is not affected. So she was happy I called her with that recommendation, and the husband was also happy that I made sure nothing is wrong with your penis. It's okay. This is what happened. We have a fix for it. This next slide is our biofeedback system. It's a computerized system. It has electrodes, has a box that I use. It wasn't something I could steal out of my clinic this morning. But I did include two pictures of this individual that came to me. She was a 86-year-old woman who got remarried. She was a widow, got remarried, and wanted to have sex with her new husband. She said she could not talk to her children about what was going on. As soon as she said it was painful when she tried to have sex, they're like, oh, Mom, don't talk to me about that. I don't want to hear it. And so she went to her doctor. Her doctor got her connected with me. And she had just a ton of tension in her pelvis. She could squeeze her Kegel, which you can see the graph goes up and goes down. So she had a good squeeze and she could relax a little bit, but she wasn't really opening up the whole way. She didn't know how to let go. So we took this at the beginning of her session. Oh yeah, and she was also the one that I'd never ever had a patient come into the clinic and ask me where their G-spot was. I think that's the one time I've ever turned red in my clinic, is my 86-year-old patient that wanted to be sexually active with her new husband and wanted to know where her G-spot was. So I said, we've got some other things to address first. She said Oprah did a special on it, and she was super excited. So we never did find her G-spot. I just kind of left that for her and her new husband to have fun and figure out. But this was her at her discharge. So now you can see there's much greater peaks. So she can squeeze, she can relax. She doesn't have that same tension that she had in the first slide before. What I wanted to make sure, and what that second graph you're seeing, the blue on the bottom, is her abdominals. What I wanted to make sure was that she wasn't over-recruiting somewhere else and under-recruiting her pelvic floor, that she wasn't compensating in some way. So I hooked up a second lead just to make sure that she wasn't cheating. And she wasn't. It's flat. There wasn't any movement on that. So she was really kind of engaging her pelvic floor and had significantly better pelvic floor control than what some of my younger patients have. So she was incredibly happy with the physical therapy and the result that she got. So pelvic floor muscle strength, we definitely do up training where a lot of the patients that we see are weak. They don't know what their pelvic floor muscles are. You ask them to squeeze and they Valsalva and they push out and they push everything out. So sometimes it actually takes us a few visits to have them actually figure out how to do a Kegel the right way, because they may have been for years doing Kegels the wrong way. There's also great importance in down training. So with that other graph that I showed, getting them to understand how to let go. Strengthening is really important, but the letting go and the rest is just as important. You create way too much tension, and we can create a lot of tension through this tissue if we don't relax. I think, well, at least in my caseload of men, the majority of them, when I tell them to, do an exercise, I want you to do Kegels, 10 repetitions 3 times a day. I had my male patient come back and he was, I'm really having a lot of pain. He was weak before, came in, had a ton of pain. He said his penis was painful. Everything around there was just not feeling good. And I was like, well, how are the exercises going? Are you getting them in during the day? And he's like, oh yeah. He's like, I've been doing those. I actually increased from 10 to 200. I'm doing 200 3 times a day. I said, well, that's your problem. I said, did I tell you to do 200? He was over-recruiting and, again, squeezing but not letting go. So he had now created kind of hypertonicity of those pelvic floor muscles. So then for the next week, he got to do nothing in physical therapy. He got to rest. He got to focus on his breathing, doing some meditation of just letting go. And as he started to relax that week, the next week I saw him, his pain was gone, and then we could kind of go back into, okay, this is what I want you to do and why I want you to do it, which then was important. I think sometimes myself and my team included, we kind of forget about the why. Why am I giving you this specific exercise? Why am I having you do this at home and not having you do something else? So now, having that experience with that gentleman in clinic, I really explained why I only want you to do 10 of these right now. We'll be able to do more, but I want to make sure the muscle's working the right way, stabilizes the right way, but doesn't create any other issues for you down the line. And we do look at core muscle strength. Definitely a physical therapist, I think, looks at this a little bit differently than the rest of the world. It's not all about your abs. I tell people not to do sit-ups. I'm not a fan of sit-ups. It increases pressure in the abdomen. It can create other issues, greater issues than kind of what we want the core to be. But I want your pelvic floor working. I do want your abdominals working, but in an isometric pattern where maintaining kind of a neutral spine position. I want your butt working a lot more than most people want it to work. And getting your hips involved. So really looking at the whole structure of what supports the pelvis. If we don't have that support, we're creating some insufficiencies somewhere and possibly creating some issues down the line. The pelvic floor muscles are really integral for continence, stability of the pelvic girdle, stability of the spine, and pelvic organ support, which leads me to this. So this is a picture for my patients that I see before they're going to have a bladder sling surgery. So a lot of my urogynecologists will send patients to me prior to their surgery. One, to make sure they know how to recruit their pelvic floor, but two, that they have a little bit better education and understanding of what their pelvic floor is. So for this picture, what I tell people is that the pelvic floor is the water of the boat. The boat is your bladder or your uterus, and you have anchors. The boat is docked, so it's got good support so it doesn't kind of get away from where its alignment is within that canal. If the pelvic floor is not working the way that it should, if it's weak, if your pelvis is rotated, if things are not even of where that boat is, those ligaments and structures are going to be stressed, and they're going to continue to be stressed, and they may break. So the last thing we want to do is have those structures that, one, are already in place naturally, but then two, after my surgeon goes in and replaces everything, and then they don't understand what that pelvic floor is doing, then the surgeon's outcomes or the surgeon's process of what they did is then at risk for failing. So I think it's important for patients to know, regardless of what their series of care, where they're headed. A lot of them like, I'm just having surgery, I don't need to see you. I'm like, actually you do. I don't want to see you later if this fails. I don't want to see you later if something else didn't go well. I want to make sure your body still understands how to recruit these very essential muscles. Oh, we're getting close to the end. And then lastly, we all do pain management pieces. It's kind of just a review that a lot of what we do by just, giving the patient some exercise. All of our pelvic floor therapists are persistent pain trained. So I think some of you may have had some contact with Nora Stern in the great work that she has been doing. Because our population is not just affected by one disorder, they're usually affected by multiple, and pain tends to be a part of that. We've worked really closely with Nora on how to educate patients on the pain that they're experiencing, why they're experiencing that pain, and really some other options that they might have outside of us or even with us to kind of cope with that. Diaphragmatic breathing, physiological quieting. I will occasionally use what's called a TENS unit, so a transcutaneous electrical nerve stimulation device. It's a little portable device that some of my patients that have had a lot of pain for long term, again, really trying to get their system to desensitize a little bit, that can be a good avenue for them to have, not only in the clinic, but sometimes we'll actually issue it for home and say, look, I want you to do this at home, 15 minutes a day, every day, to just get your system to quiet and calm back down. So we can't do anything until we get your system to calm down, and it's way too excited and it's way too good at accepting the pain response. So this can be good for those individuals. Topical lidocaine, as I mentioned, and then some of those behavioral modifications. So lifestyle changes, whether that be alcohol, smoking, that can all affect kind of pelvic floor and our ability to recruit muscles, fitness, diet changes. And this is a team effort. You know, our services really thrive on you guys sending people to us. They can definitely come see us outside of a physician referral. Most insurances will actually accept patients to come to me first, and then I tend to loop their physician in anyways, just saying, hey, your patient came to clinic today, this is what I'm seeing, this is kind of the role that I see myself playing, and this is the role that I see you guys playing. But it's definitely a good relationship between us and our referral sources. Understanding when it's appropriate to send someone to me, and I'll have my contact information for you guys, that if you have questions or want to reach out to me either by email or by phone, you can definitely do that. I ask that you not give it to patients. I think my contact information somehow gone on the Virginia Garcia website or flyer or something, and all these patients were kind of calling. And I definitely don't mind having conversations with some patients as they are scared about these services because they've gone through a lot already. And I can kind of educate them a little bit more about what it is that we do and what benefit we could provide. But maybe you just keep my contact information if you need it. And I think one of the big things that has been successful, and even my male patients, is my doc's actually letting them know that there may be an internal assessment to what my exam is. One of my male referral sources called me and he's like, I told him you're gonna put him in shorts and he has to move his junk out of the way so you can get to where you need to be. And I was like, oh, okay, that works, I guess. I'll be sure to round with him when he gets here. And the patient said, he was like, oh, he told me what you were gonna do, and I'll get situated. I was like, okay, sounds good. Because definitely for male patients, we're doing rectal exams with them, but it is helpful for them to move things out of the way. So I did appreciate the physician giving him a heads up and giving him some cueing in what would make my life a little easier. But it just was funny for him to leave me that message. We do have two kind of central locations of scheduling. Our department has gone to a centralized scheduling where there's a group of people at these, I guess you can call them call centers, really is what they are, but they are in our department, so they know us intimately. They know what each one of us does when a patient calls, and they kind of have that interaction with them on the phone. They kind of can fit that person with the clinician that they feel might be the best. There's a ton of clinicians that practice in this kind of overhead. But these numbers are given out. They can call and we'll find the location that's the best fit for them. So these are where we have pelvic health clinicians that treat children, men and women. So depending on where they live, there's most likely a provider that is near where they are. And we're growing. I have 4 positions open I think I'm hiring for right now, and one of them is another pelvic floor specialist. It is hard to find those individuals because there's quite a bit of training involved to become a pelvic floor specialist. But this is really a service line that is growing and is becoming more known, as you guys know that physical therapy is for poop, peeing, and sex, and not just, balance and shoulder and joint problems. So my contact information for you, please don't hesitate to get a hold of me if you have any questions, concerns. And I said we're having the residents kind of do some observation with us. If any of you are interested in possibly just popping in and meeting one of us or seeing kind of our clinic and more of what our setup is, you can get a hold of me for that as well. Resources, and then that's it. So I really appreciate your guys' time today, and I'm definitely available for questions that you guys have, and I'll be here even a little bit after. But I know. Oh, yeah.
So, once we refer patients your direction, how soon do they expect a response, and how long is the treatment usually?
So our centralized scheduling team, calls probably within 48 hours. They're working our Epic work queues, so you can drop it into Epic, or you can even just fax us a hard copy. Either way, we'll get it into Epic. A lot of our pelvic floor schedules are more full at the moment, so in order to actually see one of us, it's probably about a week to 10 days to get in onto our schedule. Depending on the level of the dysfunction that's there, I've had patients have as short a series as 8 visits, and I've had one, that had a really long sexual abuse in her history, in her past, that I saw 12, actually I think I saw her 14 times before I got her kind of back. But it can be as short as 6 to 8 visits.
Once a week?
Yeah, typically once a week. I have one patient that I'm seeing twice a week right now that has a really high tone level, and I'm trying to catch it before it kind of rebounds. So for her, I'm seeing twice a week, but otherwise it's just once a week for 45 minutes. Yeah. Any other questions? Yeah.
Yeah, I had a little bit of a question of your sense for physical therapy seems to take a certain amount of commitment from the patient, and so I wonder a little bit in terms of appropriate referrals. We should, tend towards the spectrum of we're not referring enough or we're referring too much, and also just wondering about people with severe mobility or even cognitive deficits, how well they do, and just speaking a little bit to appropriate referrals.
Yeah, for people that have really significant mobility issues, depending on if they can transfer to a table and they have function of their pelvic floor, that they're not paralyzed from the waist down kind of a thing, we can typically get them on the table and do some examination and figure out what's going to work well for them. Sometimes internal techniques are not what we want to be doing. The biofeedback are little stickers that go on the outside of the body. There's also internal sensors that can be used, but I'll use that for one, my pediatric patients. 2, for those patients that may have some of those mobility issues, even sometimes those that have a cognitive issue, because getting consent of me doing an internal exam may not be appropriate for that person. So doing much more education with family, with caregivers, with a center that person may be at if they're in an assisted living type of environment, and using our other modalities than just me getting in with my hands to do that. I would say you can't refer enough, because I want to be seeing your patients. We do kind of assess the appropriateness at that first visit where we're diving into the material. We give a lot of education and even about some of the activity modifications that they can do. So depending on where they might fall, say, I want you to do these things. I want you to see me in 2 weeks, and I want the bladder diary filled out. I want these completed. If they come back and it's filled out, and some of them give way too much information on there, that's the person I know that's really going to be dedicated to that. 2 weeks later, if the person comes and like, oh yeah, I didn't have time to do it. Okay, well then that series may just be more education, shorter session, because they're probably not going to buy into what I have to offer. Does that answer your question? Okay. Any other questions for me?
Feel free to come on down if you have more questions for Jen.
Yeah, absolutely. I'll be here.